and there's ways to spot people who are trying to make their empire bigger. So honest advocates tend to want to remove the causes of disease. They want to implement effective interventions, and they try to use the available resources better, right? So, we shouldn't really advocate for our own diseases because we're all in global health, We should want the best for the world, I want to reduce, to the greatest extent possible, I want to reduce the amount of suffering. And the best way I can do that is by identifying the most cost-effective interventions and wanting them to be implemented. And the focus is on the purpose and not the person. Lots of people can get very famous advocating their particular problem. And, you have to be in it for the long run. There's some, this is Ian Gilmore, he used to be the president of the Royal College of Physicians. I thought he was very good. He's a gastroenterologist, and he didn't say, I want more money for gastroenterology. He worked on liver disease. I don't want more money for liver disease. He identified that alcohol abuse was a big problem. So he was not focusing on the disease, but you're focusing on the risk factor, on the cause of the disease. And recognize that alcohol is a risk factor, not just for his disease, but for lots and lots of diseases. So, it's a risk factor for high blood pressure, stroke, heart disease, pancreatitis, liver disease, liver cancer, cancer of the mouth, breast cancer, bowel cancer, depression, dementia, impotence, infertility, road trauma, violence, divorce, domestic, lots of things, right? So if you want to do something about disease, well, it's very obvious, then you focus on the causes. And some causes are more important than others because they have bigger population attributable risks, yeah? Do you remember population attributable risks from epidemiology? So some causes are very important. Smoking, alcohol, physical inactivity. And so you focus on the cause, but not, he didn't say, we want more money for liver disease. He was trying, and then you try and make policy change, and it's very difficult. The way I got this sense of the danger of disease burden when I was in Nigeria, and we were doing this. This is the CRASH-2 trial. And this is the woman trial. This is the trial of tranexamic acid for postpartum hemorrhage. And there was a hospital in Nigeria who was recruiting very well into the woman trial, and then all of a sudden it stopped. So we thought, wow, that hospital in Nigeria was recruiting really well. These are the doctors at that hospital. That hospital was recruiting really well, and they were one of our main recruiters, and they stopped recruiting. Let's go and find out what's happened. So, when we were in Nigeria, we went to this hospital, and the doctors took us to the hospital, and it was very easy to see why they weren't recruiting, because the hospital had closed. And the hospital closed because there was no money for the doctors. Right? So the doctors stopped getting paid by the government, and so the hospital had to close. So, so we're walking around this hospital, and this hospital served a very poor community of a lot of people, and it just, the gates closed. And I was in the hospital, we were checking the records of the patients who'd been recruited, and I saw a light on. I said, it's not completely closed. There's somebody working in this hospital. Well, that's good. What are they doing over there? And they said, that's HIV. Yeah. And so that bit of the hospital did not close because it's funded by the US. you know, and it was basically, you know, they had this initiative where if you were, it was a maternity hospital, if you were pregnant and HIV positive, you could get antiretrovirals. So we had this situation where this maternity hospital was closed, but there was one piece of this hospital that you could get in with. So if you'd had your baby and you were bleeding to death, the hospital would be closed and you'd die. If you had an obstructed labor, the hospital is closed, you have to do what you can, you could easily die. But if you were pregnant and HIV positive, you could come into the hospital and get antiretrovirals. I just thought, my goodness, you know, this way of thinking about diseases is really strange if we can get a situation that's so strange as that, you know. And then why do you get that situation? Because, you know, in the politics of public health, some people are saying, right, you know, I'm the king of AIDS. You know, I'm the king of HIV, and I'm going to bring HIV treatment to all of the world, right? Because they say, oh, I'm the leader, you're all the sufferers, follow me and I'll bring you treatments, and I'll get you money, and they lobby government to get money for HIV only. And then you can get ridiculous situations like closed maternity hospital and one clinic, you know, and there was a guy, there was a soldier with a, you know, a security guard with a gun, and you know, you have to come, and if you're in labour and dying, he turned you away. But if you had HIV, he would let you through the door. I just thought, wow, that's really weird. I don't want to have anything to do with that. So that's it, really. That's my case against the Global Burden of Disease study. It's very popular. It's very popular with the Lancet. You know, you can get very high impact factor publications. I saw there's a professor in Tokyo, Professor Shibuya, published an analysis of the burden of disease in Japan. I'm not sure how much it's going to help Japan. You know, perhaps you can, perhaps it will help, perhaps it won't. I think it's more likely not to help than to help. And if it doesn't help, you ask yourself, well, what use was it? You know, what's the point of it? I don't know. Anyway, that's enough. I'd like to hear what you think now.